Hey, my name is Emily, and if you don't know me, I have a strong passion working in mental health for my career. I have over 4 years of experience in mental health, outpatient and inpatient. With that, I'm currently completing my internship at Erlanger Behavioral Health Hospital in Chattanooga, Tennessee. Many times you often see people diagnosed with major depressive disorder and bipolar 1. However, bipolar 2 exists there in the middle. So I thought it would be nice to focus on bipolar 2 and share a little bit about what that is, as many times bipolar 2 is misdiagnosed as major depressive disorder. I think as social workers who may become LCSWs one day, it's important for us to be keen and understanding bipolar 2 as well. So, what is bipolar 2? Bipolar 2 is a common disorder found within the DSM-5. There are several contributing factors to what are the causes for disorders such as bipolar 2. One explanation is that there are genetic vulnerabilities with the genes running in their family. You will often see patients come in with bipolar and diving into their family history. Oftentimes, you see a history of bipolar in the family. I had a patient the other day who both parents had bipolar, and surely enough, she was diagnosed as well. And so, another factor in bipolar 2 is chemical imbalances within the brain that can strongly contribute to the development of the disorder. Finally, as a clinician, we will also have to consider the environmental factors such as poverty, traumatic events, and stressors in a client or patient's life. You'll also find that most individuals with bipolar 2 having trauma in their past. Something to understand about bipolar 2 is that it's not situational depression or choice. Bipolar 2 is a lifelong mental health disorder that causes an individual to experience severe changes in emotions from mania to depression, which we'll dive into that deeper into that mania and depression in a minute. Another thing, according to the DSM-5, is it's required for someone to experience at least one episode of depression following a manic or hypomanic episode. Oftentimes, this is a reason that bipolar 2 is misdiagnosed, as individuals may have a hypomanic episode first to then follow into depression, as oftentimes people are unaware of what hypomania looks like. Then, through that self report of the patient, they get diagnosed with depression first. So, note that depressional symptoms are actually what makes bipolar 2 bipolar 2, as bipolar 2 favors depressional episodes with hypomania. Either way, bipolar 2 can still cause serious impairment of the individual's work and social life. It's also important to note that bipolar disorders 1 and 2 are the 17th leading causes of disability worldwide. Other facts about bipolar 2 is that the average onset for bipolar is 20 years old. Earlier onsets are associated with more severe cases, longer delays to getting treatment, and co-occurring disorders. So it's important to understand that in mental health that there is a spectrum of mild severe cases for almost all diagnoses, including bipolar 2. So within that, you see the more severe cases beginning earlier, as well as more likely to have co-occurring disorders with substances. Something else to note is that depressive episodes typically last longer than manic or hypomanic episodes. So normally you would see that the patient will experience their manic episode for a shorter period of time with a longer depressive episode. Again, this oftentimes leads to bipolar and getting misdiagnosed as major depressive disorder based on when that patient is seeking help and what they're reporting to that clinician. You'll also see that 1 out of 3 cases of bipolar have been found misdiagnosed for over 10 years of their life. Just some other important factors that I thought were good to know is that completed suicide rates are greater in bipolar 2 than in bipolar 1. 32.4% of people with bipolar 2 have reported to have attempted suicide within their lifetime. 60% of people with bipolar 2 have 3 plus co-occurring disorders. 75% with bipolar 2 have an anxiety disorder. 37% of people with bipolar 2 have a substance use disorder, and then 14% with an eating disorder. So going into what is hypomanic episodes exactly, like what does that look like? And so this looks like an inflated self-esteem. And what this looks like is that someone who's normally not overconfident and all of a sudden having more self-esteem. This doesn't have to be completely blown out of proportion. So imagine someone just all of a sudden wanting to try new things, saying yes more, overcommitting. Remember that hypomanic episodes are not as extreme as manic episodes. This also is a decreased need for sleep. So a decreased need for sleep can be based on that person. So they normally sleep 8 to 9 hours. And then now all of a sudden they're running off of anywhere from 3 to 6 hours of sleep. Pressured speech and need for talking. This is a really common thing, and it's just imagining someone who normally speaks at this normal pattern, and then all of a sudden they're speaking really fast to the point that they're almost running out of their breath, and or maybe they're just not able to stop talking. Someone who holds a normal conversation changes to needing to just go on and on and on without stopping. You also have flight of ideas. So someone, you can see flight of ideas if they're willing to talk it out. However, flight of ideas can also look like not being able to fall asleep because their brain won't stop with their thoughts. Another symptom is being easily distracted. So flight of ideas can fall into being easily distracted as their brain just won't shut off. It makes it hard for that person to pay attention to what's going on. So it's just trying to go to sleep, having a conversation, or completely something at work. Bipolar 2 patients also can get diagnosed with ADHD. However, note that that's not exactly the same thing. Increased motivation and goals. So hypomanic episodes cause that person at times to have an increased motivation in their goals. I think the inflated self-esteem or grandiose can play into this, as it makes them overconfident to achieve. Therefore, they will start beginning a lot of tasks, however, struggle to complete them. Over-involved in unhealthy activities. Then you have the over-involved in those unhealthy activities. So unhealthy activities can include hypersexuality, partying, over-drinking, and using drugs. Think about things this person would normally not do, and they have decided this is what they are doing. This can look like someone who's a faithful person, talking to multiple people, but it can also look like someone who normally doesn't go to parties all of a sudden wanting to party. A hypomanic episode is related to disturbance in functioning, but is not severe enough to require hospitalization to meet all the criteria according to the DSM-5 with these symptoms above. And so this is something important to note about bipolar 2, as the hypomanic episodes do not require hospitalization because, again, it's not severe enough to scream something is wrong. Remember that hypomanic episodes can be very subtle, and the clinician most really needs to get to know the person in order to see it and be asking the right questions. Because again, oftentimes bipolar 2 will end up hospitalized due to their suicidal ideation within a depressional episode. So with that depressional episode, we can also look at those symptoms as well. And so it looks a lot like major depression. And so with that depressed mood, you have to remember the individual and what their baseline looks like. So a depressed mood can look like pessimistic mindset, saying things like, it's never going to get better. What's the point? And at times you can also see it's in their physical demeanor. They're slumped over, curled up, flat facial expressions, severe lack of motivation in all activities, including caring for oneself. You see severe lack of motivation in regular activities, skipping class, not visiting with friends or family. They stop showering or caring for themselves physically. This can also look like they're not brushing their hair anymore. They're not brushing their teeth. They don't care what they're wearing. Again, just thinking about what is this person normally like and are they acting their normal self? Significant weight loss or weight gain. You can see these things with stress and depression, as well as finding someone who loses their appetite or significantly gains their appetite. This can also play into that severe lack of motivation, as they can be someone who cared about their health before and now they just don't care. Insomnia or hyposomnia, so that inability to sleep again, or oversleeping is also extremely common with bipolar 2 when they're major depressive. And so sleeping 12 to 14 hours a day, but they also may be getting up constantly in the middle of the night. Agitation or feelings of restlessness. Agitation can look like irritability or feelings of restlessness that can look like inability to sit down, constantly doing something, or rather, their mind just cannot stop. Fatigue, so just that abnormal tiredness that is just unexplained with no energy being utilized. Feelings of worthlessness or excessive guilt, so thoughts that they're just not good enough, they're not likable, they're not strong enough, just those overall thoughts of negativity toward their values. And this is just same for that excessive guilt, so you can a lot of time within conversations find that in the person. Indecisiveness or inability to concentrate, so hard to make decisions or an inability to concentrate and just being easily distracted and just can't focus. And then recurring thoughts of death or suicide, so just repeated thoughts about wanting to die. This can also look passive, like I just want to go to sleep and never wake up. I don't want to do this anymore. And eventually these thoughts tend to progress into more direct things, such as I want to end it or I want to die. And so, you see a lot of major depressive in bipolar 2, and most people think about bipolar 1 whenever they think of bipolar. And so, what's the difference here? And so, bipolar 1 favors manic episodes with higher manic symptoms, whereas bipolar 2 can favor hypomanic episodes and favor depressive episodes. So, they're very different. So, both have depressive episodes and a type of manic episode. However, the bipolar 1 favors the manic episode, where bipolar 2 favors your depressive episode. So just know bipolar 1 is way more likely to experience mania to the point of hospitalization, whereas bipolar 2 is more likely to seek hospitalization due to suicidal ideation. You can also see in this chart, it just kind of like gives a better overview, just a more helpful understanding. You can see to the right here, the mania can be accompanied by like psychosis or delusions. This can also look like someone having auditory hallucinations, which can be similar to schizophrenia, but that's a very different thing. And then both can experience the major depression. And then people with bipolar 2 are more likely to experience that hypomania that we talked about earlier. So, how can we as social workers help that person through having bipolar 2? So that awareness to symptoms, understanding those things is really important. Understanding those things is really important. So that awareness to symptoms, relapse and warning signs, which we're going to break into in just a second. Education with medications is extremely important as well. And then that therapeutic approach that is evidence-based. And so the first thing I'm going to go into is just looking at the common early warning signs for mania. So the same things that we were talking about, but this is a great resource you can find on Therapist Aid. They have a lot of worksheets on there that you can use. More energetic, feeling higher in another world, easily distracted, senses seeming sharper, colors more vivid, ideas flow quickly, more talkative, suddenly feeling creative, irritability, spending money more freely, sleeping less, anxiety, feeling rest, even with little sleep, increased sex drive, feeling especially strong or powerful, drinking or drug use, elevated feelings of importance. So I think they do really well in making this very clear for people in common words. The next one is looking at the common signs of depression. The sadness, less talkative, worry, irritability, social isolation, restlessness, less interest in people and activities, ideas feel slowed down, difficulty focusing, less energetic, aches, pains, um, things like that. So it just really breaks down those basic words for people to understand. And these are both a worksheet that you can give to clients, and the link is right there on the presentation. So the next one is helping them to identify those different stages of bipolar. So please note that it doesn't always look the same with people with bipolar 2. And so, like, it mentions here you have that baseline with the normal mood behavior. You also have like early symptoms and warning signs, they begin to appear. And then, the late prodrome here, the symptoms of early prodrome progress and become more severe. And then they kick into that mania and depression. And so sometimes it just depends based on the trauma. If someone experiences a trauma, this can also progress very quickly and almost to the point that it's very hard to identify if they're distressed. But if they're in their regular mood, their regular routine, it can be very predictable to see as long as they're keeping on top of it. And again, this is all on therapistaid.com. It's a great resource. So mood logs are also a really great way to help them in identifying warning signs for where they are in their cycles. And so that mood log is a place that people can identify their mood for the day. Keeping SMART goals in mind, challenging your client to set grounded times for when they reflect and keeping that, making sure that they have good awareness of their symptoms. And otherwise that can be very challenging. And so I think this is a really great thing that they can print off, and they can keep a really clear vision of where they're at as long as they're doing it. And so just using the SMART goals of like when they're going to be logging, it can be really important. And so this is also just like another example of a mood log. There's just different things, and everything's different for every person. So sometimes, one thing may work for one person and the other thing may work better for someone else. And so this is just another scale. So they can even, use it to kind of see where their moods are going on this scale. And like I said, the mood logs are all on Therapist Aid. And so the next thing is just thinking about teaching your client about the importance of education and their medication is extremely important. Knowing that difference between medications, the side effects of those medications that they're on, and the ability to self-identify differences within themselves. This is also why the mood log can be extremely important, as it helps the client to more objectively see how their medicine is working for them. And then also you kind of see here, different medications that someone who has bipolar 2, they can take anything from, the antidepressants to the anti-anxieties, mood stabilizers, all the way up to antipsychotics. And this is all coming from NAMI.org, which is also a really great resource. And so moving into this education, one of the first things when it comes to education of medication is awareness of side effects. So most pharmacies will provide not only consultation while at the pharmacy receiving medication, but also papers that include brief education regarding those side effects of the medication and what those meds are used for. So this is really important to keep in mind, as one of the biggest side effects to medication is suicidal ideation. Suicidal ideation is one of the most common side effects to most psych meds. So teaching that client this, and in general those side effects, and to talk to their pharmacy and read those papers is extremely important, especially for them to ask the providers questions about those side effects of their meds. It's also important to note that over 60% of people with schizophrenia and bipolar disorder report obesity and weight gain within their medications. And so physical health issues are common for people experiencing psychiatric disorders. So also providing those resources regarding nutrition and exercise should be really important to keep them and ourselves within competency. So let's go into what else we can do here. And so that can come into our evidence-based therapeutic approaches with our clients. And, looking at cognitive behavioral therapy, I looked at several different studies and looking here, as we stay within our line of profession, one therapeutic approach has been cognitive behavioral therapy. And so, through clients attending CBT alongside psychiatric medication, clients with bipolar 2 have been found to have a decrease in recurrence of hypomanic and depressive episodes, as well as clients with bipolar 2 were measured through the internal state scale and the Beck Depression Inventory during the study. And the study encouraged that CBT is going to be used in addition to the psych meds for best results, reducing hypomanic episodes. So this is just a basic scale. Just looking at this basic scale and understanding this, just the behaviors and what we do affects how we think and feel, which then can be reoccurring into our emotions, and what we feel affects how we think and act. And that progresses into that same thing of what we think affects how we feel and act. And these things are just all reoccurring, and they can go which way or another. And so just seeing that as a visual, I hope can be helpful. The next thing that you can also see, this evidence-based to treat bipolar 2 therapeutically, is eye movement desensitization reprocessing, which is also known as EMDR. Studies have shown that the cognitive impairment found within the symptoms of bipolar 2 can have positive correlations with early childhood trauma. Childhood trauma and stressful life events have been commonly recognized for individuals with bipolar. However, it's often neglected. And so EMDR was created in 1989, and it was originally used to treat post-traumatic stress disorder. However, over time, it's been found effective for other psychiatric disorders as well. And so in that, you have to do a lot of training in order to competently do EMDR, but the neuroscience behind it is extremely fascinating, and I would highly recommend just getting into looking into it, as it's a very fascinating approach therapeutically into helping someone. Is one thing it does is it really helps to use like mindfulness. They also have things such as complex. It's very interesting, but the neuroscience behind it is basically just the brain is protecting the person from reliving their trauma. So instead of remembering the full story, the brain will store bits and pieces of important parts in the memory to warn the person to prevent any trauma. So if you look here, you have that baseline, like this person's just living their normal life, and then all of a sudden something happens to come across them that day that triggers them toward that memory that's traumatic for them. And so instead of actually remembering this traumatic experience over here, their body automatically kicks them into that fight or flight mode to then makes them remove that trigger from themselves, and they go back to baseline to never remembering that traumatic experience. And so they're not actually removing or addressing this traumatic experience. And so within EMDR, you'll see that it will help that person to connect these two, and it will help that person to connect these, but you're also training that person to come at it in a healthy way, in a way that they can help themselves cope with that traumatic experience their body is trying to protect them from. And so it's very fascinating. And so the next one we're going to look into is just dialectal behavioral therapy, which is a common thing used for bipolar as well as borderline personality disorder, which you can see a lot with bipolar 2. So a study had shown that the idea of all behaviors are learned. This is a basic idea behind DBT. And so it was originally created for borderline personality disorders, suicide, and self-harm, which again are all common things you can find in bipolar 2. DBT is to assist individuals to regulate emotional responses to triggers or stressors. And so it's just that same concept behind it. It's just to help people in their emotional responses to their triggers and stressors. So it's just there to help them cope. It's been found to be a really effective therapeutic approach in treating bipolar disorder and other psych disorders as well. So this is just a basic chart to review those four major concepts within DBT. Please know that this is not the only therapeutic approaches that have been found beneficial to bipolar 2. There's many other approaches, but these are just a few popular approaches that have been found evidence-based and beneficial to the disorder. So if you look here, these are the four cores of this DBT approach. And so mindfulness, being aware of the present moment without judgment, emotion regulation, understanding, reducing vulnerability to emotions, changing unwanted emotions, distress tolerance, getting through crisis situations without making things worse or accepting reality as is. And then you have interpersonal effectiveness. So getting interpersonal objectives met, maintaining relationships, increasing self-respect in relationships. I really find DBT interesting as it really comes down to that person and like their life skills. And it's just a very practical approach. And I find all three of these very fascinating. So I'm a little biased. So these are just some therapy resources that I thought would be really helpful to have. So these are like some free online support groups for people with bipolar 2. They have all kinds, like they have, they have them for LGBTQ. They have them for the Black community. They also have them for young adults. And then they also just have like a general one that you can attend. And so they do try to, find different people and different populations. And so it's very interesting the way they approach it, and it's all for depression, bipolar. And then they also have these free therapeutic resources on therapistaid.com. They have so many different free worksheets. You can get a membership and get more stuff, but you honestly don't even need it. It's so great. You can also get a lot of free education off NAMI. I've referred so many people to NAMI to help understand themselves more, because they really know how to approach bipolar 2 in a simple manner. And then you also can help people to find therapists, providers, and professionals through Psychology Today. They have lots of different things on there to help people. And so these are some great therapy resources that you can give to clients just to help them if they have bipolar 1 or 2, or if they have depression, honestly. So here are the references. I greatly appreciate you listening to me talk today. I'll try my best to post the slides as well, if you just want to keep this per reference. And I appreciate you guys so much, and I hope that you learned something from this.